Well, welcome to our workshop. My name is Chung Win, and I'm going to sort of lead the first part of this presentation. Can people see the slides from where you are? We're not sure about the lighting issue. So, we're going to be talking about this project that we're doing called Lay Health Workers in Colorectal Cancer Screening Among Chinese Americans, a CVPR approach, CVPR Institute meeting. This project, the name that we actually use for it is Healthy Living Chinese Lay Health Worker Outreach Project. Elaine, can you just say what it is in Chinese? This project is funded primarily by an NCI R01 and also support by an NCI U54 grant. We have a big team, and we'll go through the introduction in a minute. This is our team, our CVPR team. We have a community organization, this Nikos Chinese Health Coalition, and I have, this is Kent Wu, the executive director. Ling Chao, project director. Let's see, Christina, Yip is right here, Nip is right here. Karina's not here. Ying's not here, right? The UCSF, which is one of the academic groups involved, is the Vietnamese Community Health Motion Project. We're based at UCSF. I'm the PI on this grant. Steve McPhee, who's not here. Dr. Janice So. Dr. Jen Lei. Mr. Ching Wong. He Lam's not here. Dr. Pasik's not here. And Jimmy Gordon not here. Dr. Stewart was at UCSF, but she moved to UC Davis, so now we have a extra partner. And San Francisco State, Dr. Adam Burke, and Dr. Jun Wang, who couldn't be here. And then from the Chinatown Public Health Center, another community representative, Lei Chen Feng. Just having a picture of us. You look better in pictures, maybe better in person. All right, which decide? Okay. Wait a minute. They Photoshop you. Okay, all right. We're not supposed to see that. Just kidding. All right. So this is the outline of our work, our discussion, and I think we have like 90 minutes, and I don't think that we're going to take 90 minutes to do the talk. We'll about 30 to 45 minutes at most, and then after that, it's time for discussion, questions, answers, challenges, anything that you'd like to do. I want to spend just a couple of minutes telling you about Lay Health Worker Outreach for those of you who don't know particularly what that is. Our CVPR planning process, and then really get in depth about how we implemented our CVPR, and then at the end we have a discussion. So that's the talk. So for lay health workers, how many people already know what community health workers are? I don't want to bore you. The WHO definition. This is the formal WHO definition of CHWR. They're also known in many other names, commonly community outreach workers, promotores, and lay health workers. And as we were doing this project, actually, it turns out there's some, lack of clarity about what it means to be a community health workers versus a lay health worker. They're kind of very different model. The way that we see it is that the typical community health worker model is someone who actually employed full-time or at least a lot of time to do community outreach. We think lay means lay. I mean, lay means somebody who's not doing this as their profession. So we define our program with lay health workers as people who fit the definition of a CHW, people who live in a community, are selected by and accountable to it, and work after receiving a short-defined training. But they work in a limited outreach program on a part-time basis. They're not full-time employees. As a matter of fact, many of our lay health workers have other jobs or going to school or whatever it is that they do. So we really take people from the community, not just employees. Very briefly, why are community health workers important? Again, you all know about this. WHO primary health care approach in the 1970s, resurgent in the 1990s, prompted mostly by AIDS internationally, I think. And the limitations of what we recognize now as clinical care, practice-based clinical care is very limited, so we need more outreach work. When we did this grant, or we were thinking about doing this grant, there were a couple of really good data summary studies. And this is important because I think everyone assumes, if I ask you how many of you here think lay health worker or community health workers are really effective, who says yes? Yeah, and I mean, I think that's from the ground. I think we all believe this, we all know this. But when you look at the literature and see what the evidence is for effectiveness, it's not as clear as you would think, right? So maybe the literature is not so good, but that's what's out there. So the Cochrane Review 35 years worth of data, and they only found 43 published randomized controlled trials worldwide, actually. 35 of them from high-income countries, 15 focused on low-income and minority populations. And here are the health issues that they found and effectiveness in. So they found it worked increasing immunization uptake, improved outcome for certain kinds of infectious diseases, and promising for breastfeeding promotion. There are some data that I'm not showing in the United States for breast cancer screening and cervical cancer screening. But at the time of this particular review, which ended in 2001, those data wasn't actually even there yet. So if you're implementing this, you have to at least think about this. Does it really work, right? So you need to understand that you need to show to yourself and your stakeholders that it works. At the time that we wrote the grant, we thought there are these gaps in the literature. There's a lack of high-quality studies that showed intervention effect, what I just said. A lack of studies with men. Most of the studies with health workers, community health workers, tend to focus around kids and women. So the question is it a model that works with men? Clearly, we are working with Asian Americans. There's a lot of studies with that population. And then the other thing that comes over and over again is that there's very little description of what works within an effective community health workers program. So if you ran it and it worked, and someone else wanted to run it, but they can't afford or can do all the things that you've done, which part of it can they take? And there's very little out there that tells you how to do this. So we decided to do a project on this. And I'm just going to show you the planning process. So we focus on Asian Americans in this particular grant. Just briefly, there are 17 million Asian Americans now in 2010. There's almost 6% of the population. It's the fastest growing racial and ethnic group. It increased by 46% in the last 10 years, compared to about 10% in the general population. And the majority of Asian Americans are foreign born. Just briefly. We also went back to what we were doing to justify what we wanted to do. So we've actually ourselves have published several randomized controlled trials at UCSF on lay health workers with Vietnamese Americans. So I don't really want to get into it too much, but we published the cervical cancer pap testing study with 1,000 women in AJPH in 2007. That was effective. And then we did one with breast cancer screening that we published in 2009 with 1,100 women. That was effective. We can talk more about what that means, but that's not what this presentation is about. So we had that track record when we went into this proposal. We had the fortune of having actually a CVPR infrastructure that was being established in San Francisco before we started this project. There's a network called the Asian American Network for Cancer Awareness Research and Training. That's ANCART. It's a network that was funded by the NCI in 2000. It actually is still funded, so it's now in its 13th year of funding. And the goal for ANCART, among other grantees like it, is to build infrastructure in cancer control research. For ANCART, specifically Asian Americans. For the other networks, they do Latino, Native Americans, African Americans, rural Appalachians, other places. And one of the explicit goals for these things, because it's funded by the NCI, the National Institutes of Health, the goal is always at the National Institute of Health to do more research. So one of the underlying idea behind these networks when they were funded in 2000 was to begin to formulate grant-funded research. So that was helpful to us. And these are the sites, at least in 2000, of the ANCART site, and we're one of the sites in San Francisco. So at the time that ANCART in San Francisco was funded, our focus was Vietnamese and Chinese, which are two Asian American populations. We were focused on tobacco use and hepatitis B. But we also had these other priorities. And the second one is the one I wanted to point to, is to adapt CVPR from UCSF and the Vietnamese communities, like the Lay Health Worker Project that I showed you, to the Chinese community in the San Francisco Bay Area. So this for us was a very important process because San Francisco is, 25 to 30% Chinese. That's great community organizations, great people, but there's very little research coming out, at least formally in the literature, with Chinese Americans from San Francisco or Northern California area. So we felt like this was a time to do it. And from UCSF's perspective, we had a lot of expertise with Vietnamese American work, so we thought we could link those two together. This is an organizational chart. The only point that I want to make here is, if you look at the top, what I was saying is that the Vietnamese Community Health Promotion Project, even though it sounds like a community-based organization, it isn't. It's actually a UCSF organization. And the other side of that column is the Chinese Community Health Plan, which is a community organization, all right? So when we built this network, we said, okay, the academic side is really the Vietnamese side, and the community side is really the Chinese side. So what are we going to do some CVPR coming out of this with the Chinese community? That was the ultimate goal. And then if you go down to the bottom right, we established a Chinese council, which is basically our advisory / steering committee body. That was kind of a vague body. There was some decision making, some advisory, you know how it is sometimes. We're just creating something for the first time. There were a bunch of representatives there. Forget about the other stuff on the left side because that's a different part of the plan. So the Chinese council is where I want us to focus on. This is where the CVPRC got developed. Then the topic. So what's the topic that we picked? This is, as many of you know, colorectal cancer is a very common problem. Screening for colorectal cancer actually is one of the most effective clinical intervention you can do to improve health. And of course, we want people to be, the word here is compliant, because that's the way they use it in CHIS, but to be adherent with cancer screening. And if you look at this data from 2003 and 2005, which is around the time we wrote the beginning to do this work, the non-adherence rate for white is 42%, and for Asian it's 53%. So there was a disparity. And for the Chinese, it was 48%, so a little bit less, but there was still a disparity. So we picked a topic, or we thought about a topic that was very important, that could be preventable, and that there was a disparity. So the Chinese Council basically looked at this information that I've just presented to you, and it says, okay, let's choose colorectal cancer screening disparities as a topic. Everyone was sort of bought into that. The council appointed one of its members, Nico's Chinese Health Coalition, which is an organization / coalition, it's a little bit of both, to be the community lead agency. And then we came up with some general idea for a pilot project grant ideas, and the Chinese Council approved it with some feedback. And I think, okay, so then we established a team. This team was established in about 2005 to do this pilot project. It seems like a lot of the same name that you saw originally, which is good. We had a Vietnamese team at UCSF. We have the Community Health Work Program at San Francisco State, led by Mary Beth Love, and then the Nico's Chinese Health Coalition and the Chinatown Public Health Center. So we put together this team. We did this, we got grant funding, a small local grant to do a pilot project, and then we published it in 2010, although the work was done between 2005 and 2007. And basically, the pilot itself is very straightforward. We trained 8 lay health workers, one of whom was a man, because we weren't particularly looking for men or women, we just took whoever was good, about colon cancer, how to recruit participants, how to conduct health education techniques, and then they each recruited 10 participants who were eligible for screening, and then they did 2 outreach sessions with their participants. And then we measure a pre and post intervention survey to see what happened. And we were able to recruit 73 participants, 20 of whom were men, which is, again, something new for us because we weren't working a lot with men in this model. And very simply, we showed a pre-post effect. This is a single-arm study, one arm, no control. And basically, if you look at having had an FOBT, which is the third one down, of course, they started out with none because we asked that people who come in didn't have any. And then after 5 months, there were about, I think, 58% that actually had a test. So in a single-arm, non-controlled study, this seems to work okay. Actually, I thought 58% was pretty good, actually, over 6 months. So we thought, okay, this is good enough for us to do a bigger control study on this. So then we planned for this application. So the 3 organizations, San Francisco State, NICOS, and UCSF, wrote this application. In the process of writing this, we decided that traditional Chinese medicine practitioners was an interesting area for exploration as outreach worker. Can we work with people who are completely trained a different medical model to do colon cancer screening outreach? We thought it was interesting. We thought it was important. Chinese community obviously uses a lot of traditional Chinese medicine, so we thought that was interesting. So we put that into the grant. One very important thing is that we decided that we were going to work like a CVPR team, but we were not going to say we're doing CVPR. this is actually, as we discuss this, a very important decision for every CVPR team to think about. Just because you're doing CPR doesn't mean you have to tell everyone you're doing CVPR. Because I think one of the things that happens when you do that is you just raise the bar for yourself. You just make it much harder for you. If you're in a different grant mechanism, if you're in a CVPR grant mechanism, then you have to say you're doing CVPR, right? That's clear, right? You have to meet the grant request. But if you're doing other kinds of grants and you say you're doing CVPR, then you've just basically raised the bar for yourself when your competitors don't have to do it. So we decided that we were going to do it, but we're not going to say anything about it too much. We weren't going to measure it. We were not going to really, and so that's a decision that I think we made. There's pros and cons to that, and we can talk about that. It's a discussion point. We submitted the application in 2008. We got really good comments and reviews, but there was a huge methodological problem in the grant that we disagree with, actually. From our perspective, from a CVPR perspective, we did not want to change our research design. But the objection was so strong that we knew that if we didn't change it, we would never get it funded. So we changed the research design. You see that in a minute. But we all discussed it. We all agreed that it was the right thing to do to change the research design. And so the second application was funded in 2009 for 5 years. So I'm actually going to stop there for just a second, maybe for any questions that's related to what I just presented before we go into how we're doing since we got funded. Okay.
I was wondering if you could say a little
Actually,
bit
maybe you can say who you are, where
sure.
you're from, just so everyone knows.
I'm Kaylin Joseph from UCSF. I was wondering if you could say a little bit more about your decision not to talk about CVPR in the application and how that related to the critique of your research methodology, because it sounded like they might have been connected, that you didn't want to change it because from a CVPR perspective, it made sense. So do you think that the fact that you didn't discuss CVPR in the original application made your methodology sort of less convincing?
Well, we were told, and of course you're never in the review sections, you don't know, but we were told that there were two pitch camp in our review. A lot of people bought what we were saying in terms of the research design and the CVPR-ness of it. Basically what we were saying was the control arm needed a lot more things to do. That's a classic CVPR thing, right? You do a control study, the control arm should get stuff. And we do get stuff in our control arm, but we offer the control arm stuff during the study, and the methodologists just basically said, that's not going to prove your point.
Because it's not a real control.
The way that, okay, let's just go back to the design. We proposed that the intervention would have the lay health worker outreach for colon cancer screening, and the control would have lay health worker outreach for nutrition and physical activity. That's what we were going to do. And we said we were going to show that lay health worker outreach worked to improve colon cancer screening. And the methodologists actually very appropriately said, if you did that, you did not prove that lay health worker outreach worked. All you're proving is lay health worker outreach for colon cancer worked better than lay health worker outreach for nutrition worked, right? So they're right. I mean, they're technically right on the standpoint of that. So we had to address it that way. They were not worried about the CVPR, the methodologists who were critiquing it did not worry about that. So that answer your question?
Yes, thank you.
Other questions? Please say your name.
Alyssa Nickel. I'm from a community-based organization in San Francisco, Shanti Project. And I was wondering about this, how you developed your research idea with the Chinese Council. It seemed like, tell me maybe I just heard it wrong, that you went to them and presented, here's this information on colon cancer or colorectal cancer screening, and then they said, yeah, let's do that.
Mm-hmm.
So normally with CVPR programs, they say that, yeah, the question should come out of the community, but it seemed like you kind of gave them the question.
I think, no, I don't agree with that. I think, you remember that we started out doing tobacco and hepatitis B.
Yeah.
Halfway through the ANCAR project, the Chinese Council already decided to do colon cancer screening. So the topic was already selected naturally. We didn't pick that. We came to them with actually the intervention idea. So we said, you want to work on this, from UCSF side anyway, from the UCSF side came and said, oh, you want to do colorectal cancer screening? How about lay health worker outreach? So I think it's a little bit of back and forth. This is an interesting question, actually. Like, what does it mean to have become with the community now, right? And I think we can have that discussion maybe at the end, because it's a pretty rich question, actually. So.
they said that you're, so I'm Aaron Peach, I come from Montana State University. They said that you were kind of decided against kind of pursuing a more explicit CVPR approach because you're worried about kind of raising the bar for yourself. What sort of things do you think you would have had to do if you pursued a more direct CVPR?
So it's very interesting. Our grant says, we had language, that our CVPR language. We had a section on dissemination. We had a section on sustainability, you know, the kind of classic things that you do for CVPR grant. But we didn't say we're going to do a CVPR grant. And the thing that we were worried about is, reviewers are pretty sophisticated now. And so if you say you're doing CVPR, there's a whole bunch of criteria, which I'm sure we're all talking about now. And they'll say, no, they're not. And that's a critique. That's a straightforward critique, right? So we also weren't going to spend our money measuring CVPRness. That was the other problem. Is if you say you're going to do CVPR, implicit in it says, how do we know you're doing CVPR? You have to measure it, right? You have to actually study it. And we felt like the resources that would go into measuring CVPRness was better off going to doing the work and funding the community organization. Because to be honest, if you're going to measure CVPRness, that means more researchers and more data type, pitching in to collect more data. So that's less money for the work for the community and so on and so forth. So that was a conscious decision. I'm kind of speaking a lot, so I don't want to.
There's another hand that was back there. Yes.
Yeah, I know you said you use the traditional medicine practitioners, but is the phenomenon of lay health worker outreach, is that familiar to the Chinese American community, or is that something that you had to initiate and introduce?
We want to take that over.
Well, the people that we incorporate, I'm Adam Burke from San Francisco State, and Dr. Jun Wang is in China right now. She is the medical anthropologist on our team from San Francisco State who is working with the traditional doctors in Chinatown. So, especially with the herbalists, they're definitely not sophisticated in terms of research process. So this was a new concept for them.
How about community acceptance? That's where we're at.
For the lay health
How do
worker
you
or the
oversee them?
For the lay health workers or for the TCM model?
I thought they were both. I thought you used the traditional medicine.
That would be a smaller part of our grant, which we'll get in a second.
Sure.
So the TCM is a smaller part.
So for the lay health workers,
Do you want to speak to how appropriate lay health workers for Chinese?
Yeah, I think you're right. In terms of the concept of lay health worker is not even, there's not a lot of activities that have been using lay health workers. So because I noticed that when we were trying to find a Chinese translation for the term lay health worker, we have a lot of discussion around that. How do you even come up with a good translation in Chinese that the community feels that they understand the term. So the word lay health is quite new concept in the community. So we end up translating it as kind of equivalent to a community in terms of Chinese community health worker. Because there's no good translation for the word lay in Chinese. Yeah. So I think it's a new, to me, I work in the community in Chinatown as a health educator, so that has been a new concept in the community.
Yes.
My name is Neva Jefferson from the Civil Nursing Organization in Washington State. The community health worker, it's pretty new out there in the state. And the lay health, the thing that I'm looking at is health. So when you choose these people, it says you choose it from, they live in that community. I think that will make you like today license, or they give them the right to go out to do like how they just teach to collect information, not giving advice or things like this is what you need to do in order for you to be healthy. It's attached to lay health. So that's my concern, because I've been in the state of Washington. That's the problem. We're trying to get community health workers to be considered as registered at the state level. one is a big thing. So, but my looking at this is appropriate to me. But my concern is the health part of it that attached to it. Do you allow those lay workers to give, advice? In that respect, I'm trying to figure out, because I know there's limitation, as he said, what they need to do.
Could everybody hear the question?
Yeah.
So the question was basically around, I guess, the legitimacy, the licensing of the community workers with the barrier in Washington of having people become certified as health workers, and then the amount of advice or guidance that you provide in health. Does anybody want to take that?
I take a crack at it, but if I can add on. I want to make distinction between two types of lay health worker. One, earlier we talked about general outside of lay health worker. I don't know what Washington requirement, state requirement stuff, but I explain to you what our lay health worker definition is. For the colon cancer project, our lay health worker is basically the person in the community who have meet some criteria, such that they have a social network. Their friend, they have some minimum requirements that are able to read or to write some of their language, and they are sociable. They're able to concern about their friend and their work health issues. And they are not expert, as Dr. Dung said, they are not expert to give you health advice at all. What they need is to give you very information, very specific information, such as you need to go get tests, and this is statistic. And the bottom line, the lay health worker is not to spend his or her personal information or advice, rather than is follow the practice as go to get a screen for colon cancer, which anybody can dispense the information. Doesn't have to be licensed, doesn't have to be anything. It's a matter of how is that lay health worker motivate their friend and the network to go get screened on that regard.
I think that's a good point. I think actually the true reality of the matter is you go to the community, people are telling people health advice all the time. There's no control whatsoever, right? So that's how we felt was, okay, if they're gonna do that, let's train them to do it right? So your concern is very legitimate, though. People would be out there telling them all kinds of stuff, so.
On the other hand, I also want to specific why you're talking about lay health worker. On the control side, on the TCM, which I don't know which later we're gonna talk about, the lay health worker is not regular lay health worker anymore. They are herbalists, because in order to have a lay health worker to have certain knowledge in the Chinese medicine, it takes years to practice. To spend minimum of some very sophisticated explanation of the health between yin and yang and cold and hot and food, all kinds of stuff. So for conveniently, we just record the herbalist and acupuncturist as representing a lay health worker, but they are not quite lay health worker, but we use them as a lay health worker.
Actually, that brings up an interesting point. We just submitted a paper on this topic of using indigenous healers as lay health workers. And in some ways, they're not really lay, and that was a question we debated about whether we call them lay health workers, and for convenience we did. But they're professionals in a sense, and herbalists are not licensed in California, but acupuncturists are licensed. So actually, it is within their scope to do this kind of education. For the herbalists, they're more like the lay health educator, lay health worker. But I'm not sure what.
No, that really educated me. Yeah, I really get to the point where I come from.
Right.
Yeah. So.
If you do have.
Now I understand, because no matter herbalist is still medical, it's
Sure.
health.
Right.
So
But-
that makes me think that's very legitimate.
But in the eyes of the state, though, they're not
Yes,
licensed,
yes.
so there is maybe a certification issue that you
Yeah.
need to look into. But it's an interesting issue because in the United States, internationally, there is a fair body of work on using traditional healers to work with the public health system because they've got their social networks, they're trusted by the community, they're in the community. So if you can teach them, they're actually a good source of health information. But in the eyes of the medical community, they're not licensed, so there's a gray area there. It's an interesting topic.
Yeah. Now I understand.
Lee Chung,
I just
again.
want to add, I think the concern is very legitimate, and we are concerned too, because, as we are giving health information, as a profession, like health educator, and we are concerned that these lay health workers are going to give the correct information, or they're not supposed to give medical advice, right? So we actually, in our training manual, we have a very strict a training manual and a flip chart. When we do the training, we tell the lay health worker, you need to follow everything that we teach you here. Okay, so, and if anything you cannot answer, you should just say you cannot answer, and I'll try to find out from the team. So that's a concern that we want to try and make sure that the information they're giving out is just within the flip chart and the training manual. The other part, I think, the labor workers themselves are concerned too, because they are really people from the community, and they actually, at the end of the training, they have asked us how do we assure that the community will accept them as a legitimate person? They actually were asking us for like nameplate and name tag, and so that give them the licensing aspect of it. So we actually have made a tote bag so that they will be carrying their tote bag wherever they go, and the tote bag always have the 3 research team members on it, and also a name tag that they use in all their presentations. And also, of course, Elaine is always there to support the lay health workers. So I think that seems to help the lay health workers to feel that they are the legitimate, trained person to go out. Because in the community, they actually encounter a lot of people in the community selling different things, and so they were telling us, how would people react to them? Would they think that they're trying to sell something too, just like on the street selling? Yeah. So yeah.
So
This is a question.
yes, I was going to say that in terms of in the consumer's eyes, I think it's a very good process for them to go through. Also, they go through the training. They feel some legitimacy because they complete the program, and then they get a diploma from us that recognizes that they've gone through the training program. Okay, sorry for that question.
I'm trying to filter this through communities that we work with the most are really homeless. And we're developing a peer navigator, which sounds really similar. And I wondered if you entertained other language than lay health worker to get away from all of that, those trappings of is it professional, is it not professional? It sounds like these are really peers working with people who are confronting whatever the issue is, colorectal cancer.
Yeah, I think in translation, how does it go in Chinese? Can you just literally retranslate what you use?
Yeah, well, because we use the Chinese term 社區保健員. 社區 is literally community, 保健 is keeping health, 員 is a person. Yeah, so, so that's the best we can translate, because even when you're mentioning peer support, because the word peer support in Chinese is not that common also.
Okay.
Because I was working on another project that we are using peer support, and in Chinese we call it 朋輩, which is close to what we're talking about. They're friends. They're same piece. They're the same level. So I'm trying to introduce. I think as we work on the project, I think we are also trying to introduce some new concept and new terminology in a community. There's something called peer support, there's something called lay health.
There's a very practical reason why we call them lay health workers, at least in our grant description. It's people understand it. When we actually go to the community, we use different terms, and I think the question of did you need to put the word health in our translation? It's actually very interesting. We're doing another project with other Asian communities, and the word health does not come up, or sometimes the word educator doesn't come up. Because some people use the term lay health educators, and that means something really different, an educator. So the term gets adapted to the community in that language. So.
It really depends on the culture, because one of our groups actually called their lay health worker as community health leader, because in some ways that really gives them some weight and sort of really being proud of their role. So it's a lot of it is really depending on the culture of the group that you're working with.
Question right over here.
So I would like to know what were the challenges when you were recruiting the community leaders or the community health workers, and how did you overcome them? in terms that it wasn't any.
But let me just do a
Yeah.
couple more slides and we'll answer that question, because that's actually part of the implementation process, so, let me get on with it. So just because we got this funding, we have 3 aims, and a classic sort of NIH grant description. So we're doing a cluster randomized controlled trial comparing the colon cancer, colorectal cancer screening education delivered by the lay health workers, which is the intervention arm, compared to a brochure, which is comparison. That's intervention, and the brochure is comparison. We had a second aim, which we thought was very important, which is it's not just to show whether or not things worked or not. We also wanted to understood how did things work or not work. And so even if, and from a grantsmanship point of view, it's good, because even if it doesn't work, you can at least show that you have something comes out of it. And then the last was this aim that we were talking about, which is the TCM practitioners. And I just want to refocus that this is a very small part of the study. The TCM part is very small. Most of the lay health workers are not TCM providers, not herbalists or acupuncturists. So this is a very small part, which we'll talk about a little bit more detail. So this is the typical study design. So it's a group, what we call cluster randomized. So the person being randomized is actually the lay health worker, not the participants. So we would recruit 52 lay health workers. We distribute them randomly, 26 on the intervention side and 26 on the comparison side. They go out and recruit 312 participants. So what's that? It's 12 per 15. 12. Yeah, it's 12. That's in math. My math is bad right now. So 12 per lay health worker. Each of the lay participants will undergo what we call a pre-educational session survey. So they'll just do a survey. That's our outcome measure, actually. Then over the course of a few months, they do, the intervention side get exposed to 2 lay health worker sessions on colon cancer screening and brochure. And actually, I forgot to put on here, they also get a couple of follow-up phone calls, actually. And then we do a post-educational session survey to find out what happened as the outcome. And the comparison side, after they do the survey, they get lectures on nutrition and physical activity, delivered by a health educator, not by the lay health worker. And then we measure the outcome at the end. So you get the pre-post measurement, what happens before and after. The intervention really only got lay health worker. The control didn't get any lay health worker at all, and they got a different topic altogether. But they did get something. One study design issue is they could have gotten nothing, because that's a classic control design. But we kind of felt like control participants need to get something. And actually, we didn't show the post-intervention activity for the control. The control group also, the comparison group also gets the lay health worker intervention after we measure the outcome. We decided the control group gets some more. So we thought this was going to work. We want to give it to them too. Any question about the study design? It's kind of pretty straightforward randomized control model. So.
Did the reviewers respond to that?
Well, no. See this part right here. This part right here was the part they had a problem with when we did the original grant. So the original grant was this box was going to say 2 lay health worker sessions on healthy eating and physical activities. That's the original grant, and they didn't like it. So we had to substitute 2 health educator lectures. They're getting the same information, really. It's just I guess the mode of transmission of the information is different. So. Okay, I'm going to show you a couple of pictures. And I'm just going to actually turn it over to Ching a little bit. So the core of everything that we do is called the flip chart. So the flip chart is where all the technical information resides, so that the lay health worker who presents it has the information at their fingertip, right in front of them. I call it, actually, can I see this one? I call it my never fail PowerPoint. Because you were seeing me struggling with my PowerPoint presentation earlier. So you can always present like this, all right? And so this part faces the participant. I got it backwards, I don't do it right. This part faces the participant, so they get very little text. They get a lot of pictures, but the back part faces this is what I'm wishing I have right now, cheat sheet, that they can talk through their points. So we'll pass this around for you. And then they just go through it like this. And you're basically the participant, and I can be the lay health worker, and I got all this cheating information back here. But this way, if they forget, they actually we tell them, if you forget, just read what's on there, and then you'll always be okay. So this is the core. You want to talk about the flip chart a little bit?
Yeah, that's basically also that answer your question. If they're not professional and licensed or whatever it is, so the lay health worker basically restrict to the language that they read to hear. We don't want them to say more, we don't say less, and exactly what it is. They can derive a little bit different from different speaking styles, that's all they can do. The structure you probably, Dr. Morris said about it, straightforward, they have the front and back. And how do we create a flip chart? I think it derived from the first pilot project we mentioned earlier. And then from there, we add on, based on the critique and whatever from the focus group study right after that. We add on, become one of those very good flip chart, which is reviewed by, it takes about 6 months to finish, believe it or not. They go through doctors, scientists, community, translator. Elaine Chow, she do most of the translation, and go to by review by San Francisco Department of Public Health. So we have, and Dr. So, she's a psychologist, so she have all kind of people in different angles to target the text. We chisel every single letter, words, and then finally come up with this flip chart. But before that, it's not finished yet. We still have to conduct some pilot study and focus group with the lay health worker, and we have the participant randomized, and we pick it up and we write up and see. We have one more final review, and then we'll get it out.
So the flip chart, just to be clear, had multiple level of community input. So actually, community people were actually in the people who helped to develop the flip chart. It was reviewed by the Chinese Council, actually. We ran it by the Chinese Council, which we talked a little bit about. And then we did participants, focus groups, and so on and so forth.
The question over there.
Can I talk about the IRB process with having the community so engaged with developing the materials and the intervention? I mean, I've had such a difficult time with that, our IRB, that I've become, just full disclosure, I share minimal information.
With the IRB? Yeah, those people, they're not
But
used to what you're doing.
How do y'all do that? How do you approach it? Do you have someone on your IRB that is your IRB receptive to that participatory approach? Have you sensitized them, or do you just give them minimal information?
What is the exact problem that you're referring to on community or review?
Well, I love that you all had so much community input on the actual materials. And I have found that it's very difficult to explain the importance of that sometimes to the IRB, because they're so concerned about HIPAA and really human subjects protection, that they're not as sensitive or as interested in the process by which you actually come to develop the interventions and so forth.
Yeah, we've never had a problem with our own IRB, and I don't know necessarily that they're the most enlightened. The issues around material development for feedback, there is really no research involved unless you're doing a focus group or something that requires a consent form, right? So at the last level where we show the flip chart to our focus group participants, those people are research participants. They sign the consent form, they look at the flip chart, they give us feedback. But at the development level is just getting different people to input. So they don't even, our IRB doesn't even care.
So you just show them the final product, but you don't say that the community is helping you develop
The material? So is that statement what gets you into trouble, is why is the community developing you develop materials? Is that what
Yeah.
I
Well,
think-
Not get you into trouble, but it opens up a whole another conversation about.
Well, I'll flip
But
chart.
how valid the scientific information is being delivered? Is that the?
Well, and there can be concerns about, at what point is it research and all of those things.
I see.
It's a gray area.
That's interesting. Okay, we haven't had that problem. Community inputs and advice is always considered like advisory, so they never thought of it as even research. They don't even look at it. So, right? Is that correct? Janice, you deal with them a lot. So.
Yeah. So I mean, a lot of times, like we would even be, mentioning that we have like community advisors, community consultants. So those would not, from the IRB point of view, at least from where we have been working with, is that they would not consider those as research participants. I mean, they are our, kind of team members or partners. Although from a CVPR perspective, participants also are our partners. Although they're sort of the role would be very different because a consent process would be involved, and they would be told exactly how we're using, why we're doing this study, why we're asking their input, and how we're going to use their input afterwards. But in terms of the continuous community input, I mean, those are not considered as human subjects at least from our IRB point of view.
Do y'all translate everything into English for the IRB?
they are all like English and Chinese version, like for this project, our target population is Chinese.
Yeah,
So
yeah.
we are submitting things to them that particularly assessment, consent forms, all the documents in both languages. But our IRB does not require us to provide the education materials. We describe it that what we are developing, what being used, but the actual, say, for example, the flip chart, I mean, they never require
We don't have to
us
submit our educational
provide.
materials.
Wow.
We
Wow.
don't. Because it's considered low risk behavioral research, particularly if your materials are promoting something that's standard of care. Right?
Yes.
So if you're promoting colon cancer screening, who's going to say you're doing the wrong thing? As long as, if you're promoting something different, like enrollment in clinical trials or something that's more difficult, then it gets kind of tricky. But even then, because you're only teaching people to do something, not giving it to them and making them do it, it tends to be considered low risk behavioral research, at least from our IRB. They tend not to want to look at all that materials.
I wonder if that can help you. It can narrow down the role of the community. If you have a group of people, different people, you can narrow down the community only advise in the cultural issue or translation, but not the science, and have the expertise to only review the certain part. So I don't really think it can help you. But in our flip chart in the back, we all recognize, all the community agency, whoever it is, we recognize and they have contributed to develop this material, period.
Thank you so much.
Yeah. So I just want to show you a couple of items in the flip chart. We have basically 3 big sections in the flip chart, but one of them has to do with the medical information. This is what colon cancer is. This is what colon cancer screening is. And as you can see, the front part is all in Chinese because our population is mostly immigrant and English proficient, so we didn't feel the need to put English in front for them. Other projects we do have English in front. And then the back is both English and Chinese, so that for 2 reasons. One is that if you wanted to read it, at least you know what we're saying. If you wanted to take our flip chart home. We always had that problem is we're so CVPR that all our stuff is monolingual Asian. And then other people say, well, I don't understand what you're saying. So, we have to put the English stuff on. We also have cultural beliefs that we stress, like for example, which one is this? This one is? So the 3 characters, well, you speak to
It's like happiness, longevity, and prosperity, which is the 3 things that most Chinese want. I mean, you have the 3 things, you are set for life. Who doesn't want that?
Who doesn't want that?
So, but in order to get that, you have to take care of your health first. So, you see.
So that's we pick a culture, so we have a lot of culturally in the flip chart. The culture itself is in the flip chart. We don't necessarily think that culture is a barrier, but cultures raises questions, and you want to use the culture to answer the question in a way that's appropriate. Training. So here's, I'm going to leave it to Elaine. And you know what, I did forget one thing, Elaine. So let's go back to this for a second. There was a question about recruitment. Let's talk about that with the lay health workers and recruitment.
I'm just going to describe a little bit about how we recruit our lay health workers. So I'm Elaine, I'm the community project coordinator at Beacons Chinese Health Coalition, and I oversee the day-to-day of the project. And what we do in terms of recruiting lay health workers is we use the Chinese media in San Francisco, newspaper, radio, television stations. We submit press release to these media, and they will help us announce a project and that we're recruiting lay health workers. And we also recruit through other CBOs in our neighborhoods. We have sent flyers to organizations that are affiliated to us, and just the rest is just by word of mouth from people that we've worked with in the past, and past lay health workers also refer new lay health workers when we are recruiting for another wave. So those are the main channels we recruit our lay health workers. I would say the most effective way for us is maybe through other CBO referrals, because they are already connected to all these people in the community. A lot of our lay health workers get services from these CBOs, and then they hear about our project, and they happen to be interested in health. So when they hear about the project, they come to us and want to become one of our lay health workers. In general, each wave, there are 4 waves altogether in this project, and each wave, after we send out our flyers, announcements, we will receive about
an average of about 80 to 100 inquiries from interested people who wants to participate in our project. And so actually getting the word out is not the hardest part because it's relatively easy to for people to hear about the project, and we do get a lot of responses after we publicize our project. The harder part is finding the right candidates. So we usually go through a process of phone screening. When they hear about the project, they usually would call our office and we'll talk to them on the phone, explain to them about our project. And after they learn more about the project, some are not so interested anymore, but some people are still interested, then we'll go through a screening of eligibility because there are certain criteria that they need to meet in order to participate in the project. And after they've met all the eligibility criteria, and if they're still interested, then we schedule an in-person interview with them because we feel like doing this kind of Lehigh worker work, the personality really plays a big role in the work that they do. They need to be like personable. They need to know how to talk to people, and that kind of stuff. So we feel like an in-person interview is important, so that we can get a feel of what the person is like and talk to them more in depth about their project. And then after interviewing maybe about 40 people each way, we will find 12 to 16 good candidates, which would eventually become our Lehigh workers. I feel like it's hard to find the right candidates because there are a number of criteria they need to meet. First of all, they need to meet all the eligibility criteria set by the researchers, like their age. They need to be San Francisco residents. They need to, and then the second thing is the time commitment, because our project actually requires about a year of commitment from the time they join the project, starting the training until the end of the project. It takes about a year. So that time commitment sometimes could be a barrier for some people. And also they need to be able to have a large social network, because we really depend, for our project, we depend on the Lehigh workers to recruit their own participants. Our idea is for these Lehigh workers to reach out to their own friends and families, coworkers, relatives, people that they're already in contact with in general, and invite them to participate in this project. So it's important that the Lehigh workers have a large social network so they can actually find interested participants to come to their sessions to learn about colon cancer. And also they need to be able to make it to our training date, because we have a few days of training that they need to attend before they go out and teach people about colon cancer. And sometimes because we're working with a lot of very busy trainers, it's hard to get everybody scheduled together. So there would be times when we find a really good candidate, but because they really couldn't make it to those training days, then we have to give them up and find somebody else. So those are some of the barriers to finding a good Lehigh worker that I can think of right now.
Yeah, okay. I'm really curious about your LHW workers. Are they mainly volunteers, or do you give compensation to corresponding to the work?
Yeah, our Lehigh workers actually get compensated for their time. So like I said, the time commitment is about a year with maybe around 30 to 40 hours of work. And we do pay them $1,000 for the completion of the project.
When we do the actual recruitment, we actually downplay the stipend part, so most of our flyers won't even mention the stipend. That way we get people who are just genuinely interested in going through training and learning and being these volunteers for us.
So training, this is important, because I think we can't just recruit them and set them loose. We got to teach them what they need to know. And so I'm going to turn it over to Elaine and actually reach and Ching, all three to talk about the training.
You are the principal.
We all acquire names after 4 years of working together. So Ching is the one actually, Ching is one of the trainer, and then Elaine and myself and Janice also. And
Ask the doctor.
Yeah, ask the doctor, because Ting is known as the doctor.
Practicing with a license.
Okay, so the training session for the intervention arm, of course we don't call them the intervention arm, we just call them the lay health workers who's doing the colon cancer prevention side. And we actually have developed 2 training manuals, and one is called the orientation training. And this orientation training actually is for both the intervention arm and the control arm. And we gave them like a 4-hour training. Basically, that training consists of what is randomization, what is research. You know, we want to inform the community about this is a research study, and then the participants, whoever you recruit, are going to follow you. They will be randomized into either a CRC, which is colon cancer prevention arm, or the nutrition arm. So they were told right at the beginning. So I think we learned something in the process of how to educate the community on what is research and what is randomization. So I think we went through a lot of discussion right at the beginning with the, I guess I'm from the community side, and how to kind of how to work together as a team to bring out the topic in a very simplistic way to tell the community that it is a study. And so Ting, you want to say anything on that?
Basically, the randomization in every cross the population is not just the Chinese, but also Vietnamese and other population as well. So the only way we can explain to them is just people who understand the culture, what does that mean, and then pick something live example, and then use that example as a randomization, and they answer your question, and they realize that is randomization, why they will have control and intervention. That's how we do it. Right, and straightforward sign language, they don't understand anything.
Yeah, we actually followed many scenarios.
Right.
We all remember 4 years ago.
Just simple thing
What
is
would be the
2-part.
simplest way to
Yeah.
inform the community being randomized?
Right. 2-part of plan, one with fertilizer, one without. That's it. I mean, simple like that.
We
You
went
can see
through
it.
that, but we didn't pick that one.
I know, but we pick a better one. Even that simple, we still have better ones.
Yeah, because I think the example that we had before was from the Vietnamese community, and then I think the Vietnamese community have more of a agricultural
We
background.
had farming examples.
Yeah, they use farming
It didn't work.
examples. Right, so when they come to the Chinese immigrant population, not that many of them are from the farming background, so we will say, oh, I don't think we will work, you know. So then I think we then kind of from discussion and talking, we actually came up with a very simple one, which is it, which one are we using as
We don't know,
because
but in the book.
I think we end up using is like picking a number from a hat.
Yeah.
You know, like it's equal chance. So it can be a hat, and it can be then become a computer because the computer generated. Jen, I'm looking at Jen because Jen is the one who put their names into the computer, and then we even as trainers do not know which arm are they being randomized to. So so like the computer would generate which member. Like Elaine started with the recruitment, right, and then she came up with all the chosen lay health workers, and then the names are put into like a hat and like a computer, and then so because in Chinese randomization we actually translate it as computer generated. Yeah, there would be no fun put because the computer will tell us, oh, you are in this team, you are in that team. This seems to be simple enough for the community to understand. So this is the first part where we do the 4-hour training on randomization and research. And they were done by already randomized into the 2 arms already. We trained the first 6 or 8 lay health workers who are the CRC arm, but we actually don't know which arm they are in as a trainer. And then the next day, another who will be trained, and they are the control arm example. Yeah, on the same thing. Yeah.
And recruitment, they're also trained on recruitment.
Oh, that's right.
So when they go out and recruit, they don't know which group they're in. So it's not that they can use that information to say, I'm teaching about colorectal cancer, will you participate in this study? or I'm teaching about nutrition, they are actually blinded. They don't know which group they're in until they finish recruiting all their participants.
Yeah, so for both the lay health worker and the participant that they recruit, they do have to agree, whichever that you are being computer generated to, you have to agree.
You mean
The lay health workers.
lay health worker
And then the
the-
participants are
Yeah.
basically follow the lay health worker. If the lay health worker was randomized into the intervention, then all her 15 participants will be in that, in the polling license, right?
So Elaine, when you were recruiting, were you also telling them that they were being recruited into a research project?
Yes, they do, yeah. And actually, all the labor workers are also considered a research subject. They need to sign their informed consent.
Were there any critiques about the relatively low compensation, either from the community or from reviewers when you put your grant out? I sit on a review panel, and there's increasingly more trends towards equitable budgeting and transparent budgeting and making sure that enough money. And it's actually very difficult to do. So I'm always just interested in hearing how people address that.
From review, we didn't get anything about the money. No one said we spent too much or too little, at least on the lay health worker you're talking about.
And how about the community? Did people say, you want me to do all this for free?
You know what? I don't think people would think that's too little. Most of people think it's a lot, a lot of money for the work that they're doing, because they're already interested in learning more about health. So they really see that I'm here to learn all these things and I'm getting paid to do it. They really find it like a great deal.
That's really a testament to how much they trust you all. I mean, it's fantastic that you get such a positive.
One of the things that we haven't talked about is what happened at the end. And what happens at the end, at least in all other projects, and we can speak to the Chinese, the lay health workers really love their experience. Because they learned something new, they learned some new skills, they did things they thought they couldn't do. And so they get more compensated than just the money. The money, I think, is nice. It works out to be like, what, $1,000 for about 30 to 40 hours worth of work. So it's not minimum wage exactly, but it's not lots of money. But they seem to be okay with it.
Yeah, they really appreciate what they learned from the whole training and what they can also do for the community. And a lot of positive feedback from the lay health workers. Yeah, they like that.
And at the end of their piece that they've done, there's a little celebration. They get a certificate of completion, photograph of the whole group, which actually is, it's really rather inspiring. It's like a little graduation party. And then,
There we go.
then there's an opportunity with Nikos potentially for future work. So it is workforce development in a sense too. So that's something that the group is looking at.
But from an IRB perspective, on the consent form, we did say how many hours, and then essentially you can divide it up. It's like pretty much, I mean, in San Francisco, because it could vary according to your location as well. So it's equivalent to something around like $25 an hour, like 20, 25, something like that. So we do spell it out, like it anticipated how many hours.
I
Yeah,
think
to make it transparent.
the opposite problem comes up, which is people say, I want to do this, but I don't have $1,000 for my lay health workers, right? I mean, that's limited resources, right? And what we justify is we say, look, the $1,000 and the 40 hours isn't all outreach. It's a lot of it is research stuff. We have to train you. I mean, normally you don't have to train people in how to do randomization, stuff like that. So there's a certain number of hours that they're being asked to do essentially research work, not education work. So we could argue that if you were calculating a $20 an hour wage, it may come out to be a lot less than $1,000 if you're just simply teaching them how to teach others. This is a research project, not just an outreach project. So.
Yes, because many of the hours actually we're including those, including documentation, like some of the forms that we're requesting them to fill out for us, and they are part of our research data as well. Yeah, so those extra time.
I think a lot of people are just happy to have the opportunity. When you're new to this country, you don't speak the language. To have an opportunity like this to do something other than the kind of work that you're doing already, or not have work, I think that's what they are really interested in. Got a question right over here?
Yeah, I'm curious. I know this wasn't the main part of your study, but I'm curious if there were any difficulties in terms of training the lay health workers who are also TCAM practitioners, I've noticed through the flip chart, the only time that traditional medicine or anything gets mentioned is through the common belief section. I'm curious if there were any practitioners or anything that wish that there was a more
Future attraction.
Yeah.
Wait 5 minutes.
Well,
Okay.
So quickly, I think I just want to let people know we do have another manual, which is the actual training manual, which consists of 2 6 hours, almost like a whole day, 9 to 5 trainings, 1 week apart, where we train the lay health workers on the colon cancer prevention information using the flip chart, and also do a lot of role plays. And through their role play, the trainers pair up with them to observe the way how they deliver the information in a correct manner. And also we do a lot of, the second day we do a lot of training about presentation skills, how do you deliver a message, observing some quiet participants or the very knowledgeable or the very outspoken participants, how do you deal with them, some of the presentation skills that we want them to have too. Because basically once we help them the information, they're on their own, delivering the information in small group setting. But we have a training area on that too.
And in the training, they teach each other. So actually, the model that we took here actually was they listen. So Ching or Lei Chen would tell them about what's on the flip chart. Then they get to deliver the content of the flip chart to a partner. So, and then the partner gets to deliver the content of the flip chart to them. So they actually get to hear it twice and say it once. So that's how we try to reinforce the education information that we give them. And it's very straightforward. So.
Yeah, and between the 2 sessions that they're teaching, because they go out and deliver 2 sessions, and between the 2 sessions, which is like 1 month apart, we bring them back for a 2-hour follow-up training. So, after they deliver the first session, what kind of issues that comes up, are there any problems, or are there any barriers? So that's the whole part of supporting them, as a follow-up session.
I'm going to move to the next last, look at this picture, and you can tell them about this picture.
Oh. So Ching, you want to say?
This part of the lay health worker training is to, I think majority of the lay health worker, they are younger than 50-year-old, and also the people that recommend to have something more than a FOBT or cholecystoscopy or sigmoidoscopy, talk to them about that kind of test instead of speak to them with week. So the best thing to do is to take them to a hospital and show them what cholecystoscopy and sigmoidoscopy look like. I don't know if they need to explain to their participant or not, but at least as a lay health worker, we want to equip them with knowledge. So this is actually seen in the Chinese hospital. You take the lay health worker and show them how is a cholecystoscopy and sigmoidoscopy work, and the instrument and how and so forth and so forth. And actually, many people appreciate this little work because they never seen it before. Otherwise, even you are a patient, you never seen the whole thing. You just go and get sleep and you get it done and get out. And they are very eye-opening for them, and they appreciate that.
So let's switch quickly to the call. What do you want to talk about call?
Part of the intervention component is actually doing follow-up calls, and in fact, to actually make both intervention side so as much as equivalent as we could do from the research side of it, in terms of having equivalent number of contacts. So the lay health workers actually at both arms, they will make calls to the participant, and main goal for that is really to keep in touch to remind them of the next activities. And so we focus a lot on the flip chart, which is a tool and an essential tool for the lay health worker to deliver the health messages, basically. They are messengers, right? So those are the messages. So in between the 2 sessions, so the lay health workers would make a follow-up call. And we use this as one of the, this is a tool that we use it to train them as well as for them to actually use it as a record, as a log, so that we are getting data from them, learning actually, as a way to guide or to help guide the conversation, not to make it like a robotic-like, but we provided them some quick guideline by steps, like 4 steps to do a call. call, including hello, as one step, so make it really simple. And then the log include, even though it looks like a lot of words, but in our training we say these are suggested scripts. So it's up to your personal conversation styles, your relationship with your participants in terms of the way how you talk about it. But we provided them enough materials or guidance so that they have some idea. So what could I say in these calls, And also at the same time, we're obtaining data, and one of the part of the data we're interested in getting is knowing where the participants are regarding their readiness, their stages of change, their readiness to get screening. And then we provided suggestions about what to say, when someone, talk about a barrier, what to say when someone is not ready, despite you already told them the whole flip chart, all the information. And also the way to support our lay health workers in saying that it is okay, even though they are not ready, because there are people, it just take them longer to digest the information. But some who are ready, maybe just a little bit of reminder, a little bit of empowerment, and they would do the next step. So this is one of the, what you just saw is one of the components for the training.
Let's skip ahead a little bit. So these are the survey sessions, just so you can see, and then the control group gets these lectures on nutrition information. These are actually very exciting. They love it, actually. We actually have a whole educational program that involves using your hands and all kinds of stuff. And we actually see people walking around doing this, so I like it a lot. So it's interesting. We talked about lay health worker appreciation ceremony. Validation of their work is very important. Switch to the TCM, the small pilot TCM really quick. So
Sure.
interesting.
Right. So basically, this was the third arm of the grant, and the National Cancer Institute was, the review committee was intrigued by this. This got points for innovation. And as was alluded to, these are professionals in their own world in a sense, but they're not licensed. The herbalists are not licensed, acupuncturists are licensed. And one of the thoughts behind this, one of the motives for integrating these individuals as lay health workers is they understand the health beliefs of the community, which is very important because then you can speak to people at that level culturally very appropriate, and they get the message, you understand each other. So there's some good cultural connectedness there. Also, they have their own networks. These people have patients, especially the herbalists, have 20, 30 people coming in a day, so there's a lot of community contact there. And they're trusted members of the community. One of the herbalists who was in the project, in the study, delivering the intervention, he's been in his little corner office in Chinatown for, I think, 30 years, the same spot, so people know this fellow. So there's a lot of involvement, there's cultural relevance, the language is the same. And one of the other possible benefits from this, especially in terms of acupuncturists, Dr. Wong, who's faculty here, and myself were both, in addition to, she's an anthropologist, I'm a social psychologist, we're both also licensed acupuncturists. And one of the advantages potentially of that community is they have to get CEUs to maintain their license. So this can be built into their training, and they have to get CEUs anyway, and some of them will find this compelling because they want to work with the biomedical community because there's opportunity for basically networking with that system. So there was some incentive for them to participate also. So just like the development of materials for the regular lay health workers, as your question, there was a whole separate set of materials developed in conjunction with the herbalists and acupuncturists, with their patients and other community members who do not use traditional Chinese medicine. So also a very extensive process of developing materials around traditional medicine and developing this model of an integrative piece. The bottom slide there basically is saying to use the best of biomedical and traditional medicine. And people really got that idea. It really speaks to the community, and it was I think, successful model. We're just implementing it, and we have the data, so we have to look at it, but quite intrigued by it.
So this is really trying to mold two thought systems together. Can we do it in a way that both the practitioners and the recipients buy it? The challenge was how to message, but I think once we showed the messaging, everyone loved it. People liked it. They thought this was exactly how they thought about their health. And this idea that we separate traditional care from biomedical care is our problem, not their problem. They live it all the time. So that was just a big point. I just wanted to show you a couple of study results today. Jen, you want to just say a couple of things about this?
Sure. So this is a 5-year research project. We're in our 4th year. We have 1 more year left. along the way, we've been collecting lots of data, and to date, we have 58 lay health workers that have been recruited. We're in our final wave of 16 lay health workers right now. And we have 554 participants who have enrolled to date. 19% of lay health workers and 22% of participants are men. So we are getting, not a lot of men, but enough to be able to look at health working men as well. 62% has ever had an FOPT, 37% had ever had a endoscopy at the pre-intervention survey. Another component to the study is, in addition to the self-administered surveys, we're also doing a validation study. So we're going to be, we ask them at the end of the project, when they complete their participation in the project, to consent to us reviewing their medical records to see if they got colorectal cancer screening. So this is going to be to all the reviewers, when we write up the results, who question the validity of the self-reported screening and question the outcome, we'll have some validation data to back it up as well. So that's another component to our study. This is just some data we collected so far. We presented this at APHA when it was held in San Francisco in June, last October actually. So just some basic characteristics. This is a low SES immigrant community, as you can see. Again, it's about 22% males. In terms of their health and healthcare access, generally they have, majority have bare poor health, self-reported health, have at least one chronic health condition, 61%. 80% have visited a doctor in the last 12 months. The majority, 87%, have a regular place of care. And being uninsured was at 11%, so pretty low, mostly because the city of San Francisco has the Healthy San Francisco program and has access to care for them. So these are just some quick statistics on baseline screening. And recommendation for the screening. So 52% have received a physician recommendation. That's actually pretty low. When you think about it, everybody should be getting this recommendation if they're at the screening age. We saw the FPTs already. For endoscopy, very low, 29% received a recommendation for endoscopy, and 37% never received an endoscopy. So this is just some baseline characteristics. We don't know yet. We haven't looked at any post data yet, but that's going to be in our final year when we evaluate our study. So along the way, again, this is a research project. We have been presenting interim data as we've been collecting these waves of data. This is just a listing of the various abstracts and presentations we've done over the last 4 years. At the last APHA meeting, since we're local and we're proud of San Francisco, we had a very strong showing, and we submitted 4 abstracts and had all 4 accepted for presentation from the project. So we had 1 oral, 1 roundtable, and 2 posters. And all of these abstracts actually can be found online. If you're interested, you can just search APHA online to look at the actual abstracts.
Well, just one last slide, actually. Sorry. Right past that. I'm having trouble. Okay, last thing is, this is a CV representation. I think we talked a lot along the way about how certain aspects of CVP are being addressed by this project. We did want to lay a couple of things on about the processes that we've used in the last 4 years. We try to make a team approach and consensus decision making, so we meet monthly as a group. All of us here, and a few more people who are not here, make decisions together, the big decisions. I think the day-to-day decision often is made by Jem and by Len as things are coming up as program directors. We have lots of other meetings. We try to equitably distribute the budget. In general, about a third goes to NICOS, about a sixth goes to San Francisco State, and the rest goes to UCSF. We talked a little bit about capacity building and sustainability. We've been working a lot with our trained lay health workers. So maybe one word, a couple of words about what we're trying to do with
So we really, as a community-based agency, we really learned a lot about the research process and also this particular method of community worker development. One of the things that always comes up in any studies of the Asian American community is the need for more bilingual, bicultural workers. So this has really given us a good model to work off of. Most recently, we applied for a grant through the Affordable Care Act to educate 12,000 Chinese Americans about what would be available in terms of health insurance through the state's exchange. And we realized really the only way to do it would be through a lay health worker model. We can't provide 15 minutes of education to 10,000 people in the city of San Francisco with one worker, which is what pretty much the budget would allow, but have a cater of people who are already trained, who understand the methodology and who have the networks that they can reach out to, who fit the population that we're targeting. We're also looking into it for other work as well. Just yesterday, I was at a meeting with a team that conducts problem gambling trainings and outreach, and we talked about the possibility of using some of the people who are in our group already to do outreach for monolingual problem gamblers. Because who would know monolingual problem gamblers better than monolingual problem gamblers? So really, it's worked out really very well for us. Also, we've taken on some other research projects on the side. So there was a health plan that wanted to do a study on quality care. And so they wanted someone to talk to medical office staff to see what their perspectives were on quality care. Normally, we would have probably turned it down, but having worked with the project for 4 years already, we felt we had some understanding of how to facilitate these discussions, take the notes, and then also produce the notes in a professional way to the organization that wanted the information. So it's really developed us as an organization. I think it's done a lot for the community also. I'm just kind of looking forward to taking on more of this type of projects.
We're done with our presentation, but we're just in time for 4 more minutes of discussion, unless you want to stay longer.
So any questions or comments as we close?
Actually, I'm really interested in getting a copy of the stuff that was going around. Is that available?
So far, we're still doing intervention right now. We are not open up to the public yet.
Oh.
However, I think
We're
we
done.
have some
We're done in what,
PowerPoint.
6 months? 6 months? About 6 to 9 months. Take your name down.
You want a physical copy or you want an electronic copy?
Electronic copy is fine.
We have some PowerPoint that's similar.
Yeah, that would be good.
But we'll have to ask all the researchers, see when we're supposed to release it.
Well, we want to give them away as soon as possible, but
Yeah, I mean, I'm with APSHO, the association, I can't remember the name for it now. It's really long. But we're working on hepatitis B intervention, and it
Be
seems like
united, right?
we're part of that. But this is a project that we're working with Seattle folks, and I think we're running into a lot of the problems that you guys are talking about that I think could be applied to the project. So I'm really thankful to listen to all of this.
It would be a good fit. Yes.
I think in one of your data slides, it's looked like 80% of your, one right before this, that they'd visited the doctor and had a regular physical care is 87%. So it seemed like they're already engaged in healthcare. Is that something because the community is already engaged, or does it have something to do with recruitment and people were able to bring on to the project?
San Francisco.
Yeah.
Accessible healthcare.
Yeah, these are as limited a group as you're going to get, limited English proficient immigrants that we're working with, and this is the rate of care. So either a recruitment issue or just the way the community is. We don't really know the answer to that question.
But
This is not unusual for San Francisco.
Yeah, probably Healthy San Francisco, that's a big part of it. I think if you were to take the stats from 10 years ago, you would see an uninsurance rate of about 22 to 24%. Now you're looking at about 11 to 12%.
But it's amazing sometimes, I think, from here, from doing the focus groups with the participants, they actually might have a provider, but they might not be told that by the provider. So there's still some of the stories that the provider has not mentioned. a colon cancer screening. So that's what, yeah, but again, because it's San Francisco, right, Healthy San Francisco is really doing a lot of outreach and trying to really find a medical home for all the uninsured participants ages 19 to 64. So that has been very successful in San Francisco. But a lot of the, and then sometimes I meet participants who might have the a medical home, but then because of the language issues or a long waiting period, they might not be totally linked up yet.
I just want to make a comment. I thank you guys for the presentation because it learns. I learned a lot from it. The way you described what the lay health workers. I did not have that understanding that they have a very big educational part of it. So it really does help me to see the big picture because when you say a lay person, I thought you just pick somebody, you know, but it goes to show that the work you guys are doing is really from your heart to do for your people, what people you serve and you wanted to better their lives. So I had to take into consideration that I wish I can have this kind of worker out there, but I'm a very small group of population. So talking about the population of Asian Pacific, it's a huge population, even out in the Northwest. So, but it gives me some learning ideas and things I have to adjust to my own little community. So thank you guys.
Some of us will be here afterwards.
There's more materials up there also if you want to take a look.